And again, thank you for joining and good afternoon. We're going to go ahead and get started on our presentation. Today's Learning and Action Network will focus on reducing readmissions and more specifically on tools and approaches to monitoring them. Nancy McDonald will be leading us through the first part of our discussion. Nancy?
All right. Can you hear me okay?
We sure can, thanks.
Awesome, thank you. Well, good afternoon, everyone, and thanks again for joining our call. I'm Nancy McDonald, and I am a Quality Improvement Advisor for the Great Plains area, part of the Partnership to Advance Tribal Health. So with me today are several of my colleagues that are on the phone, but there will be 2 or 3 of us that you'll hear from the most. Carmen, who already introduced herself, but we have another individual who'll be monitoring our chat, and that's Velda Williams. She's the Quality Improvement Advisor from the Phoenix area. So Velda will be monitoring our chat, and so as we go along, if you have any questions, feel free to plug your questions into the chat and we'll make sure to address them. Next slide, please. And on the back side of things, we have Jimmy Norris, who's monitoring our slide deck for us too. So thanks for taking care of us, Jimmy. So here are the May Learning and Action Network objectives for today. We're going to talk all things readmissions related. We know that we have all sorts of different sizes of hospitals on the call with us today. And with that being said, there really is something for everyone to learn today, big or small hospital. So here are our objectives. The first one is to describe the importance of reducing readmissions, including what the linkage is with the IHS strategic plan and individual hospital Medicare payments. Number 2 is to understand how to monitor readmissions, including readmissions data with the CMS Hospital Readmission Reduction Program. And lastly, to share data and hear from other call participants about their efforts to reduce hospital readmissions. All right, next slide, please. Here's a brief overview agenda of how our time will go today over maybe the next 40 to 45 minutes or so. We'll start off by talking about why it's important to reduce readmissions and why there's such a focus on this topic. And then we'll have an overview of the CMS Hospital Readmission Reduction Program, where we'll discuss the impact of hospital payments and how to access and interpret facility level data and how to use the data to focus efforts to reduce your readmission. We will look at additional readmission level data outside of this program, and we'll explore ways to impact readmissions. And then lastly, we'll discuss how your Partnership to Advance Tribal Health Quality Improvement Advisor is able to support your efforts. Then we'll take a look at what's next or what's ahead of us, and then we'll wrap up for the day. All right, let's get into this. Next slide, please. Thank you. All right. So an important foundational component of reducing readmissions is having an awareness of your readmissions, and that is through monitoring. So we'd like to start with a polling question on this topic. Francesca, could you please pull up the first poll for us? I see we have 34 participants on the call. It'd be great if you guys could answer this. So the question is, how often are you monitoring your readmissions? Are you doing it once a month? Are you doing it weekly, daily, you don't know, or other? And then you can enter that other in chat. So we'll give everybody a little bit of time. I can hear the Jeopardy music in the background going here. I should have cued that. I don't know if we have a timer on this, Francesca. Whenever you see that they stop coming in, you can certainly stop the poll. All right, are we able to post the poll? There we go. 43% of you say you're doing it on a monthly basis. 7% are on weekly, 7% are on daily, and 36% say they don't know. and 7% say other. And so if Velda, if you notice anything that comes across the chat, you can just let us know. Awesome. Okay, well, we're going to go ahead and stay on this slide, and we're going to talk a little bit about that poll question. So the really is not a magic answer to that question in how often you need to be monitoring your readmissions for your facility. What is important is that you are indeed monitoring them, you're aware of who's coming back in your facility and why. Are they the same diagnosis or are they completely unrelated? So this slide shows 3 reasons why it's important to measure your readmissions. And the first slide is that it has a positive impact on patients. And what we mean by that is it affects the quality of the care that we as hospitals or we as caregivers give, and then also improves the quality of life for the patients. So this piece really encompasses patient safety overall. The second reason is that it's a priority locally and nationally. IHS has indicated it through their strategic goal number 2 on quality, and then CMS and the Partnership to Advance Tribal Health have also the same goals to reduce readmission. Nationally, there's been a focus on readmissions for a very long time. And then number 3 is to receive full reimbursement for care. As many of you may or may not know, the CMS has a hospital readmission reduction program where IPPS hospitals are penalized financially for excess readmissions. So to avoid those adjustments, we need to ensure that we have interventions in place to prevent them from coming back. Because even just one person, one extra readmission can throw your facility into a penalty. And we'll talk about that in the next couple of slides. So all 3 of these can be tied together to one another as readmissions are expensive, not only for the patient, but also for the hospital. The cost of hospital readmissions is enormous, and it's estimated to be in the vicinity of $26 billion annually. So it's no wonder that Medicare and others are working to reduce the amount of readmissions. All right, next slide, please. Okay, so we're going to talk a little bit about the Hospital Readmission Reduction Program. CMS's Hospital Readmission Reduction Program, it impacts hospital Medicare payments, and it offers us as caregivers valuable monitoring data on readmissions. So first off, who participates in the Hospital Readmission Reduction Program? Right now, CMS requires that all PPS hospitals are required to participate. You don't have to submit any forms or papers or anything. You're just automatically in the program. So the program monitors 6 readmission diagnoses that are typically high dollar and high potential for readmission. And those 6 diagnoses are acute myocardial infarction, heart failure, pneumonia, chronic obstructive pulmonary disease, coronary artery bypass grafting, and then your total hips and total knees. So just looking at those are obviously high readmission rates across the nation. That's why they chose these 6 measures. Another thing about this program is that it's an annual program, and the reports are usually released sometime, I think, in July. And then there's a review and correction period for about a period of 30 days where the facilities can take a look at their reports, and then they can send it back to CMS to say, yes, these look wrong. There's something definitely wrong with our report. Or if there is nothing wrong with them, you don't have to respond to them at all. But then the final reports are usually out sometime at the end of August. This program calculates excess readmission ratios for those 6 measures, and it determines what is called a payment adjustment factor for eligible hospitals. And this is based on a 30-day standardized unplanned risk standardized unplanned readmission. So as you can see on this slide, it is a pay for performance program. And so what that means that it is if a hospital performs better than an average hospital that admitted similar patients, that means they have similar risk factors such as age and comorbidities, the excess readmission ratio will be less than 1, and there will be no penalty. If a hospital performs worse than average, the excess readmission ratio will be greater than 1 and will result in a penalty. So I just wanted to mention to you, if you have any questions on this program, the Quality Improvement Advisor for PATH can certainly help. You can reach out to any one of us. If they don't know the answer, they'll work with one of us that does know the answer. So the penalty on this program can be up to 3%, and this will be on all Medicare payments, not just the diagnosis that throws you into a penalty. And I'll review that in the next slide. Next slide, please. All right, so you can see that on this slide that the payment reduction is a weighted average of a hospital's performance across the 6 hospital readmission reduction program measures. The payment adjustment factor, also sometimes you'll see as identified as a PAF, is the form of a payment reduction CMS uses to reduce the hospital's payments. CMS applies the payment adjustment factor to all Medicare fee-for-service base operating DRG payments during the fiscal year. So this is what I just said, this report gets released every late August, and then it will affect those payments for the entire next year. So maximum payment reduction is 3%. So that's a payment adjustment factor of 0.97, which I will show you on the very next slide when we're ready for that. So hospitals with a higher payment adjustment factor have lower payment reductions. I know it's backwards, but you'll see what I mean here on the very next slide. So for fiscal year 2021, payment adjustment factors are applied to all Medicare fee-for-service operating DRG payments from October 1st, 2020 through September 30th, 2021. So for those of you who are in the penalty phase, that will go through September 30th of 2021. So again, I know it sounds a little confusing for those of you who are new to the program or don't know anything about it, but these next slides, hopefully we will explain it a little better. I'm seeing a message in chat.
Yes, Nancy. Carrie Howard asked
Yeah.
a question. I might have missed this if you said it, but does this program apply to critical access hospitals or are cause exempt?
It does not currently. So that's a good question, Carrie. Thanks for asking that. Right now, only PPS hospitals, so the larger hospitals, so are required to participate in this program or are by default in the program. Critical access hospitals are not, although coming from a critical access hospital background, I worked in a critical access hospital for 20 years. I always had the philosophy as in be aware of these programs because you never know when CMS is going to require them for the critical access hospitals. Does that help answer your question, Carrie? Thanks for asking it. So for those of you who are critical access hospitals, you will not be receiving these reports and you will not be in the penalty program. However, it is very good for you to be aware of this program in the event that CMS does include critical access hospitals. We've been saying for years that CMS would never have nursing homes or critical access hospitals report into NHSN, and here we are reporting into NHSN. So a lot of those smaller hospitals and nursing homes. All right, so next slide, Jimmy. Okay, so payment adjustment factors, they are posted annually with the final rule as a supplemental data file. They're downloadable supplemental data files to obtain the payment adjustment factors. So this is an example of what you would see when you go to pull the report. The data file will contain all hospitals across the nation. So these are all PPS hospitals, Carrie, not critical access hospitals won't be in here because they don't participate in it. So the data file will contain all PPS hospitals across the nation. It's not protected data because there's no patient level data in these particular files. So on this screenshot, you can see about 8 facilities and how they perform overall with regards to the payment adjustment. So only one of these is not getting a penalty. And that, you can see that one in the middle of the screen, that's the one that has payment adjustment factor of 1. And that is the CCN number 010008. So if the payment adjustment factor is 1, they're not going to receive a payment adjustment. If the adjustment factor is less than 1, then the hospital is subject to a payment adjustment. So to determine the percent that a hospital's payment will be reduced, the adjustment factor is subtracted from 1 and multiplied by 100. So let's take the first 1 or 2, for example. So CCN number 010001's payment adjustment factor is 0.9864. I'm sorry, I need my readers on to be able to read this. 0.9864. So take 1 and subtract that number and you get 0.0136, and you multiply it by 100, you get 1.36%. And that is the percent that Medicare payments will be reduced for that facility, 1.36%. So if you have a lot of Medicare patients or, dual eligible Medicare, Medicaid, this particular facility is getting a 1.36% penalty on all Medicare claims. So CCN number 01, the next one, 010005, payment adjustment factor is 0.990. So you take 1 and you subtract that number and you get 0.001, multiply that by 100, and this facility is getting a 0.1% deduction from all their Medicare payments. So you kind of get the drift on that. The next one is 01006, 0.9905. They're going to get a 0.95% reduction on all that. So you get the picture. The bottom line is that 3% adjustment can be quite a bit. And so it's good to have a plan on how you're going to be dealing with your readmissions. Now, for those of you who did not get an adjustment, it's still good to review your reports, and I'll touch base on that in just a minute. So are there any questions? I'm seeing a couple of things pop up on my screen here.
Yes, Nancy. Cecilia Belone asked the question, when you say larger hospitals, does that mean all, no matter what size, acute hospitals?
You will need to know your designation on if you're a critical access hospital or a PPS hospital. So I know in my state of South Dakota, we have a couple of PPS hospitals that I would consider smaller, but they're still a PPS hospital and they are in the program. So if you want to know if your hospital is, if your hospital is included in this program, I'm going to go through that on the next couple of slides.
And Nancy, there's another question from Sarah Leek.
Okay.
So it is all Medicare claims are adjusted rather than claims related to specific DRGs?
That is correct. Good question. And I'm going to talk about that on slide 12. So yes, if you have one diagnosis that's putting you into the penalty, it will not just be on, so say pneumonia puts you into a penalty, it will not just be on pneumonia claims, it will be on all Medicare claims.
And a comment from Carrie Howard to Cecilia. Good question. Are there any exceptions or differences in calculation or penalty for small, low census hospitals that are not CAUSE?
That is a very good question, Carrie. With all programs, there are some exemptions. I would have to look that up for you. To my knowledge, I am not aware of any right off the top of my head. So great question. That's something that we can research for you. I'm assuming you're talking about some of the hospitals that maybe in the midst of transitioning and have low numbers. So, all right. Well, for sake of time, let's go ahead and go to the next slide, please, Jimmy. All right. So I'm a visual person, and so we wanted to walk through with your team and how you can find your hospital score. So if you want to, Cecilia, if you wanted to know where your hospital is, number one, you can always reach out to your QIA or you can email me and I'd be happy to walk through this with you. We did send the slide deck out with resources to everyone who had registered yesterday. If you registered a little late, we'll ensure that you have the information following the presentation today. So this link on this slide it's an active link. If you got the slide deck yesterday, I'm not sure how it came in PPF and if it came in a PowerPoint or a PDF, but you could type it in or copy and paste it in. But once you're on the CMS site located here, you'll click on, see this blue arrow button. I know these screenshots aren't ideal, but there is a hyperlink that says Hospital Readmission Reduction Program on the left-hand side. So you would then click on that. And Jimmy, if you could take me to the next slide, please, I'll show you what will open up. Okay, so again, these screenshots aren't the best or the biggest, but when you get here, you click on the fiscal year 2021 final rule homepage link. It's on the bottom left-hand side of this screen, and that will pull up the tables that you will need to dig into. So then you would click on the fiscal year 2021 final rule correction notice tables. That's the second orange circle from the left. And then there are two tables that will hold the data that we need to review. So the first is the Hospital Readmission Reduction Program supplemental data file. This file holds a lot of information on it, and I would suggest taking a look at it. It houses all facilities nationwide, their payment adjustment factors, so you can see if you have a hospital, 45, 50 miles down the road, you can see how they performed as well. And you can see all of your peers and how they're performing as well. So you'll see their payment adjustment factor, you'll see the peer group assignment, which we'll talk about here in a little bit, the dual proportion number of Medicare, Medicaid coverage, the number of eligible discharges for excess readmissions for each of those 6 DRGs. So for those of you who are on from the area offices, I don't know if I'm not familiar with all the names, and my screen is kind of shrunk a little bit so I can see my talking points, but for those of you who are on from area offices, you can see at a glance how all of the IHS facilities are doing as well by looking at this report. The other is the other circle, the last one on the bottom right-hand side, is the payment adjustment factor that will show all the facilities nationwide and their adjustment factors on the program. That's the one that we just showed 2 slides ago. So for sake of time, we aren't sharing those particular reports. You can get out here and click on them and it'll open up this big Excel file. They're all in one big giant Excel file. But for now, we'd like to take a deeper look into each one of the individual Hospital Readmission Reduction Program facility level reports that you receive as a hospital through secure file transfer. So again, your quality improvement advisor from PATH can certainly help you. Any other questions before we go on? All right. Okay, next slide, please. All right, so this is an example of what an individual hospital report will look like. This report will come to your facility in an Excel format, and you will see several different tabs at the bottom, just like on all Excel documents. So each of these tabs will house multiple different tables, and we'll be reviewing several of these different tables today in the next few slides. So table 1 is titled the payment adjustment factor, and will show your peer group assignment. So I only have 2 circles on this one, but this particular slide deck shows more than that. but it shows also your payment adjustment factors. So this is table 1 in your facility level report. It also shows your number of dual eligible stays, your number of dual proportion, as well as neutrality modifier. And we're not going to get too deep into that. The key to each column is indicated below each table with a description. So if you want to know, these are all labeled A, B, C, D, E, and F. That's what I mean by the key. It will tell you what is A, what is B, what is C. So you can see that in there. And then also the peer group assignment is also located in the supplemental file on CMS. So you'll be able to see, how do I compare, how does Rosebud compared to Eagle Butte compared to Pine Ridge? Are we in the same peer group? Or are we being basically compared to other facilities? So it's always nice to know who you're being compared to. All right, moving on to the next slide, please. So this is table 2, and it houses quite a bit of information, including how your facility performed on each of the 6 measures. So this one is titled hospital results. And so, by the way, these are all demo from the CMS website. It's a demo test facility. So this, in a nutshell, summarizes your facility's performance, as well as shows the number of eligible discharges for each of the 6 diagnoses, which that's very important. This is indicated by the first orange circle on the left. The middle circle shows the excess readmission ratio for each of the measures, which is also important. And then, so this test facility has 3 diagnoses. If you're looking at that middle orange circle there are 3 diagnoses that have an excess readmission ratio: AMI, COPD, and heart failure. So next, you'll see a small orange circle on the right of that. That is the penalty indicator column. So they're all listed as no, except for one on the heart failure row. And so that is because you have to have at least 25 eligible discharges in order to qualify to be in this penalty phase. So qualify to be in a penalty phase. I know it sounds crazy. So this facility will be getting a penalty because of their excess heart failure patient readmissions. Now, there's something else to consider, is that there were actually 3 diagnoses on this, you can see on this report, that had excess readmission ratios. They didn't meet the 25 discharge eligibility, but I would personally recommend you take a look at those for your facility as well, because you never know what's going to happen in the following year. It's good to stay on top of it now so you can know where you're at. So I know that was a lot of information. We do still have a couple more to go. Are there any questions before we go any further? I would say that this table 2 houses most of your information for this program. All right. Seeing no questions in the chat, we will have time for question and answer at the end of the presentation as well. So Jimmy, next slide, please. At the bottom of your report, you will see tabs that go through each of the 6 discharges for your facility. So you can see on this slide, if you have blown up big, is that I'm on table 6 on this demo report, and it shows the discharges for pneumonia readmissions. And the important column I'd like you to take a look at for this column is titled Inclusion and Exclusion Indicator. So a value of 0 in this column indicates that there were no exclusions that were applicable for this admit, and that it was indeed included in the measure calculation for this facility. So any value of 1 through 14 indicates a reason for exclusion, and then that patient was not included in there. So lots of valuable information in here, especially for your larger hospitals, and even your smaller ones who are getting your reports. It'd be fun to review these with you, to take a look at where you're at for your facility and where you can focus your efforts. So Any admissions may have multiple reasons for exclusions. All right, next slide, please. Okay, this screenshot shows if the readmission was unplanned within 30 days. So you can see this blue arrow is pointing to they had 1, 2, 3, 4, 4 unplanned readmissions within 30 days. So again, focus your efforts here. And then you can go on to the next slide. I know I'm zooming through this pretty quick. So lastly, on this screenshot, you can see that those 2 circles showing the principal diagnosis of readmission. So if the readmission was from the same hospital, you'll see it here, or if it was from a different hospital, you'll see it here as well, and it will list the CCN number for that hospital. So regardless if you received a penalty or not, these reports should still be looked at to glean all that valuable information on your readmissions. Even if your facility did not trigger for a payment adjustment factor, there's still a plethora of information that you can glean from these reports. So again, this program only focuses on 6 diagnoses, so only 6, and they're Medicare claims only. So just to ensure that you have a plan to monitor all of your other readmissions. And I know Carmen's going to be talking about that in the next couple of slides. So with that, I'll transition to Carmen for the next few slides. So next slide, please.
Awesome, thanks, Nancy. So as Nancy said, the CMS HRP reports capture a specific set of readmission measures and CMS priorities. And we do recommend reviewing these in detail when they become available, especially given the potential negative financial impacts to the hospital. But these are one point in time, as Nancy had said. And so they are also focused on a specific set of Medicare fee-for-service diagnosis groups. However, any interventions that you develop as a result of reviewing this data and making changes will likely have a positive impact on other patients. So definitely worthwhile to do. We can widen the scope of our efforts with other types of data. For example, pulling in all of the Medicare diagnoses and all patient data can round out the picture, and it'll ensure that you can create interventions for the highest priority areas. And PATH has pulled together a couple of snapshots to see what that might look like. Let's go ahead and move to the next slide. So as we look at this data, please feel free to chat in with your observations and experiences. Do you see similarities in your hospitals? Do you have active interventions or anything that works or is particularly challenging to you? So these 2 views that we see are aggregated across a subset of PATH participating hospitals. The top left graph with the blue and orange bars reflects a subset, again, of PATH hospitals and includes the top Medicare fee-for-service readmissions for 2019, the blue bars, and 2020, the orange bars, in all diagnosis groups. The numbers reflect the actual number of readmissions for each diagnosis. The data includes readmissions to all hospitals, not just to the originating facilities. And as you can see in both 2019 and 2020, pneumonia readmissions are the highest category and pretty equal for those 2 years. And in this case, also, please feel free to chat in if you've done any root cause analysis on your pneumonia readmissions or have interventions that you believe work. We definitely like to hear that and share that. So after pneumonia, we have COPD, diabetes with complications, and septicemia. And you'll also notice the unknown category. So that does reflect COVID-19 related codes, and our data teams are working on that. And that's an area where we are going to continue to provide data and information to you over time. And it just gives us a different view, a slightly different view of the readmissions. The other graph represents some information from a survey that PATH had done. So many of you had outreach from your QIAs earlier this year, and we did request the top 3 readmission diagnoses for many hospitals. And most of that does reflect readmissions directly back to the PATH facilities, not to other hospitals. And it's an interesting comparison because what we do see is pneumonia and COPD remain as our top 2 categories. and with some variance in the other categories. And so again, hospitals, if you feel like weighing in, please let us know if these differences strike you, if they give you any information, or if this is very consistent with what your experience is. There are a number of ways that hospitals can supplement this data. Workload reports, RPMS reports, and other data can be used. And again, your QIAs, we're here to support and help you in any way possible with that in aggregating data and trying to figure out what the best interventions are.
Carmen?
Yes,
This is Nancy. I just want to say, looking at these lists, 3 of the top 3 diagnoses is really, they belong to breathing, pneumonia, COPD, CHF, and people get scared, when you can't breathe. And so you need to be having those discussions, with your patients. And we'll talk a little bit about that in the next slide. So I'm sorry to interrupt.
No, that is a great observation. Interesting. Okay, so yes, let's go ahead and move to the next slide then. So these are just a few data sources that can help you monitor readmissions and prioritize your quality improvement activities. Again, PATH and your QIA, we're here to support you. We'll definitely help you with accessing those CMS reports and building a process to get them every year, as well as helping with the facility-specific reports that you do receive that are not public domain. Another thing we will be reaching out soon to all hospitals is to discuss discharge plans, which is a very important element in reducing readmissions. So if your QIA hasn't already contacted you, we will, because we have a few questions and some things that we're gathering information for. So with that, Nancy and Velda are going to talk through some key interventions and next steps in terms of our LAN activity.
Thanks, Carmen. Yeah, so I just am going to keep this on this slide, Jimmy. We'll talk a little bit about, we're just gonna kind of skim the top on this because it sounds like we might be just a little bit behind, but we'll focus our efforts significantly on these topics in our June LAN and our interventions. So talking a little bit about what some of your facility interventions might include is your risk screening tools that you utilize. There are lots of risk screening tools that are available, even just online if you want to Google, what kind of readmission risk screening tools you can use. But some include, addressing their health literacy, if they are depressed, or if they have multiple comorbidities, or if they have a lack of social support. So also a daily surveillance of your at-risk population. Your case managers and social workers and your quality improvement specialists are very familiar with these patients and what their needs would be. So I'm assuming your daily huddles will be addressing, those who are at high risk for readmission and how you plan to address those. Empowering the patients and family through education. So the only recommendation I have for you on this is just to take every opportunity to educate where you can. The support is undeniable for those that truly need it. Ensuring a smooth transition of care between entities, communication is what I like to say on that one. And then having excellent coordination with your community partners. Are you utilizing what you can to ensure the best outcome for your patient? So are you aware of all of the resources that are available in your community? Do you have routine meetings with other entities in your communities? I would just encourage you to be very knowledgeable of what is available for all of your patients. So Carmen already kind of touched a little bit on the summer focus on discharge plans. Did you have anything else to say on that, Carmen?
Actually, I was going to mention there's, terminology everywhere, and many entities use different terminology. Our initial focus is really going to be on the discharge plan as it's communicated to the patient. So as you had touched, Nancy, in, the list of interventions, making sure the patient knows and understands what they need to do and what to expect is a really important part of the discharge plan.
Great. Awesome. Okay, thank you. All right, I think we're ready for our next polling question. Francesca, could you help with the polling question? Thank you. So we are asking you, what interventions to decrease readmissions would you like to hear most about on our next Learning in Action Network? It is multiple choice. You can select all that apply. We like to bring topics that are of value to you, so your feedback to us is extremely important on this. We'll give that just a few seconds to have Francesca tally that. All right, so while Francesca is getting ready to post that, I'd like to move on to the next slide, if at all possible. Well, and then Francesca, you can post that whenever you have time. We have a great mix, but we have a lead runner on, having a discharge plan in place, and a risk assessment. Health literacy was right up there, and collaborating with community resources and teach back. Thank you guys for the feedback. We'll make sure to include that in our Learning in Action Network. We're meeting on it tomorrow. All right, so we have a time for discussion here. Anybody have any questions that they'd like to ask the team? I know we have a quiet group. I always hate to ask questions if I'm the primary speaker, but some things to think about is, are you running your reports to include your emergency department readmissions, your observation bed stays? When I worked in a critical access hospital for too many years, I would go to my business office and I would say, can you run me the readmissions or the patient list for the last 45 days? And so she would run those for me, and all the patients that were, had the same patient name would come up with their date of admission and then their diagnosis. So if you can run those in your RPMS, then I would just sit down with that report and I would just say, if this one was a stubbed and avulsed toe. This is always the example I always give. Somebody came in with an avulsion to their toe because had their toe ran over. And then 2 weeks later, they were in because they had a pneumonia. And then, they have to be in for another reason. So if you can review, what your patients are coming in for, and then have a process in place to address those that might be issues.
Nancy?
Yeah.
We have a question from Natasha Green. What would you recommend to do if you pull your readmission report and it is only a few patients? And how would you provide that information back to the leadership?
That's a great question. And so coming from a critical access hospital, I know what that looks like. Again, I would ask you, are you only including inpatients? Are you including the ED? Because you might have a patient that is coming into your ED several times, but they only make it to your inpatient once. And so you can maybe see if they're interrelated some way, shape, or another. But if you do have, my philosophy always was, one patient is one patient is one patient, and they're all just as important as the next. And so I would, if you have one patient that happens to be a frequent flyer, I think is a name that we've called them before. I don't know if that's proper anymore to be calling that, but then you have more of an opportunity to take a look at that particular patient. Are we doing everything that we can for that patient? So hopefully that helps answer that question. So I see another one here. Is it best to pull a report on only Medicare patients or all IHS patients? Would you focus on a certain age? No, I would not focus on a certain age. I would look at all. There's some interesting things that you can capture if you're including all ages. We captured an abuse case in our hospital where this 14-year-old was being abused and had all sorts of different interactions in our facilities. So I wouldn't limit it to any particular age. Very good question on the Medicare patients. So since a lot of IHS patients are IHS only payment source and or just Medicaid, I would have a process in place to pull all patients. Kind of like I said, when I was in my critical access hospital, I went to the business office and I said, run me a list of all of our patients that were in our hospital for the last 45 days. And so then they just queried it from like May 1st to June 15th. And then if they were the same patient, obviously it was in alphabetical order. So I would say have a process in place to look at all of them. It won't be just Medicare. So great question.
Nancy, Cecilia Malone said you said ED readmissions. Please clarify.
So kind of like I said, and I only know this from experience because that's not a requirement, and it's definitely not a requirement for the hospital readmission reduction program, but sometimes you'll see patients that'll be coming into your emergency department, and we'll just take pneumonia or COPD as an example. They might be extremely short of breath, and they're coming into your ED, and they see one provider, and the provider's very familiar with them and recognizes that, oh, maybe they're not so bad. You need to turn your oxygen up, go home, whatever. And then 5 days later, they're back. They see another provider. That provider's never seen them before, and they put them into the hospital when maybe their condition hadn't really gotten any worse. So I always like to recommend, if you're a smaller hospital, if you're a larger hospital, you may not be able to do that. But if you're a smaller hospital, take a look at who's coming into your emergency department too.
Nancy, we have another question from Carrie Howard. Can you share some examples and recommendations about collaboration with surrounding tertiary facilities with which you share patients, particularly data sharing and case management approaches?
Yeah, it's been a while since I've talked about this, but we had in my critical access hospital, we did the storyboard on our readmissions because we had a lot, and we identified several different things, and we ended up needing to work with one of our IHS clinics that was just north of town. And so we called them on the phone, and we said, hey, we see that there's some balls that are getting dropped because we're seeing some readmissions on patients that really, when you start looking at these patients and you actually sit down and you're like, okay, they have the same diagnosis. Why did they come back? What did we miss? Did we not include something on that discharge instruction? Did we not, what did we miss? Did we not have a follow-up appointment scheduled for them? And so what we ended up doing was we ended up getting the first 2 slots of that clinic's day, the next day for our hospital. So especially following a weekend. So Monday, Tuesday visits were for Friday, Saturday, Sunday visits that were into our emergency department. So I don't know if I'm answering your question, Carrie, but we collaborated with our IHS facility to say, hey, our patients are coming back to the hospital because they can't get in to see you at the clinic. And so they're like, oh, well, we want to see these patients. We don't want to pay for them to be in the hospital either. And so that was a great example of a collaboration that we did.
Nancy, we have a comment from Natasha Green.
Yeah.
We have been working with bringing in the larger healthcare systems community health worker program. Their team provided training to the providers, and the providers and PM were provided with information to provider referrals to this program.
Yeah, lots of focus right now on community health worker programs. And, IHS needs to be applauded because they've had these CHR programs, community health resource programs. I don't know if we called them when I was working in our hospital. I've been out of the hospital now for a little while, but they definitely need to be applauded for their community resources that they have. So yes, I think as these community health worker programs grow across the nation, we have a lot to learn from them. And, the case managers can definitely help refer individuals to those particular programs. So Natasha, if you want to come off mute, and if you have anything else to add, I'm more than happy to have you talk.
I don't know if we have any more to add, but it was just a great collaboration.
Yeah.
It was nice to see resources being offered and being able to collaborate together and discuss some of the
Right.
barriers that they experience, and just doing that networking with the other healthcare systems.
Yeah. You know, when I sat down to do my reviews, when you live in a smaller community or even a bigger community, and you've got, you know, same patients keep coming over, you get to know these people very well. You love them, you care for them. You want to make sure that they get the best care provided to them. And so when I would do my reviews, I would always say, gal, you know, if this was my mom, how would I want her to be treated? What can we do better? How can we as a team do better to make sure that this person can stay in their own home and not keep coming back to the hospital? You know, I do have to tell you one story. You know, I mean, you find all sorts of things when you do your readmissions. We found that there was one patient that just simply had a crush on the doctor. I'm totally not joking. She really liked the doctor, and it was something that needed to be addressed. So I'm sure there are all sorts of different stories out there, but
Natasha, we have a comment from Carrie Howard. In the Bemidji area, the IHS hospitals meet regularly with the larger area hospital to discuss ED transfers and case management of shared patients. It is a helpful practice.
that's great.
And then we had a comment from Tasha Peltier. Many of these programs share the same patients, and communication just helps things overall. And another comment from Paula Huske. The skilled nursing facilities were participating with Health Insights sessions like these. Isn't PATH with Health Insights?
So there are separate sections of Health Insight. Carmen or somebody else want to answer that one? You're on mute, Carmen.
Yes, I can answer to that. Health Insight is now Comagin, and we do have separate organizations. So Comagin is actually the lead PATH contractor, so you're correct. And then we do have our Health Insights colleagues who are continuing to do similar work with the skilled nursing facilities. And we do attempt to coordinate within ourselves as well. So if you have any thoughts or suggestions on that, certainly feel free to share with us, you know, with your QIA or with anyone on this group. Wonderful.
Awesome.
So I think
All
I'll
right.
sort of take over from here. This was
Yeah,
a
go ahead.
great discussion. And we want to continue to make them productive and helpful. So in addition to our polling question on specific topics for next session, we would like to drop in a SurveyMonkey link and have you give us additional feedback on the sessions. It's much appreciated.
Mm-hmm.
We want to make these things work for you and for the patients that we're all trying to care for.
Mm-hmm. And Jimmy, you can go to the next slide, please. There you go. Yeah, kind of like Herman said, please fill out the SurveyMonkey. It really helps us to help you. We want to bring value to you and your teams. So looking ahead, we'll be continuing the discussion next month in June for readmissions. So what we didn't get to today, we're going to make sure that we address next month. We'll be discussing many more interventions related to keeping our patients safe and at home as long as possible. We're excited also to announce that we'll be starting the next Huddle series that starts June 9th through July 28th on accreditation and certification in PCMH. They will be weekly brief huddles. They're 30 minutes, starting at 2 p.m. Central, 1 p.m. Mountain, 12 p.m. Pacific. And these will be followed by short open office hours for 15 minutes to help answer any questions you might have. So Velda, I think, do you want to insert the registration link for that huddle in chat?
Yes, that has just been inserted into chat, and so has the link for the SurveyMonkey.
Awesome, thank you. All right, so if you, Jimmy, can you go to the next slide, please? So there's the reminder for the LAN and the SurveyMonkey that's been put into chat. And then could you go to one more slide to Velda? This is just a list of the resources and links that we use to prepare for today's meeting. So with that, if anybody else has any questions, please feel free to reach out to your respective quality improvement advisor or how else can they reach us? Reach our QA advisor?
Yes, that's the best way. Reach out to your QIA and we'll help guide you to whatever you need.
Awesome. All right, everybody. Well, have a good rest of your day. Bye.